Hi everyone, my name's Anastacia, a medical doctor, author, and activist, working predominantly in the field of trans rights and access to healthcare. And of course, I am trans-identified myself, and I'm going to be speaking to you today on the medical ethics of gender-affirming care. So I hope that we all understand the four fundamental principles of medical ethics, and I'll recap those for you in a minute. But the idea of this discussion is really just to develop a lens and a framework through which we can apply these ethical principles to the idea of providing gender-affirming care. And I hope that this discussion and perspective will empower you to make your own decisions around this, and that those decisions will be ones that are ethically sound. So the four pillars of medical ethics, and I think these were described by Child and Burgess, but I'm sure that you do recognize them from your studies previously. And of course, those are beneficence, non-maleficence, autonomy, and distributive justice. So let's go on and examine these principles in a little bit more depth. And as I'm sure you remember, beneficence, the concept of beneficence is ready to interrogate a particular action or course of action and to say, does this provide a benefit to the subject in some or other way? So the question that we would ask when we look at a proposed course of action in order to determine if it fulfills this principle of beneficence is this act of benefit to the subject? The next principle, non-maleficence, which comes back to the idea of first do no harm. And the question that we'd want to ask here when we look at an act or a course of action is this act harmful to the subject? If we do pursue this, will we be damaging someone through it directly or indirectly? The third principle, autonomy, does this act preserve the subject's right to decide for themselves? Is the question that we've used to determine if we are complying with this ethical principle and this ethical pillar. And autonomy really just refers to the idea that people should have agency, and of course this refers to people who have capacity to make their own decisions, but does this person have agency in making their own decision, even if it's a decision that we as healthcare providers or clinicians might not necessarily agree with? And then of course the final principle of justice, which is a principle around fairness and equality and equity and access. And the question we'd ask ourselves, is this act fair and equitable? Does it fulfill the principle of justice, or is it unfair in some other way? Does it prejudice a certain individual or a certain group for some other reason? So these are the four ethical principles, and as I've alluded to, I'm sure that you are quite familiar with these, and it's a very useful framework that we have for trying to navigate our way through the various ethical conundrums that we face as clinicians. One of the examples often used in med schools or CPD settings would be a scenario where you have a number of people desperately in need of an organ transplant and only one organ. And how do you determine who to give it to? Should it go to the youngest person? Should it go to the person with the best chance of survival? Should it go to the person who's lived the most noble life, for example? And these are all very tricky sort of considerations to make. And having an ethical framework, or at least an approach like the one that we're talking about here, helps us to make the best decisions in these spaces. And often these decisions are not so much about right and wrong, but they really are about trying to understand all of the processes at play and unpack them and make the best decision possible. So now that we've recapped the idea behind medical ethics and the principles of it, there's two different approaches to the provision of gender-affirming care that you might already be familiar with, but that I do just want to unpack and describe and discuss with you briefly. So the first approach is one that we call gatekeeping. And just as the name that we use would suggest, this is the idea that someone, and in this case, this would be the clinician or the provider or the doctor or whoever it might be, really holds the ultimate authority on making the decision as to whether someone gets access to the services that they want. And the concepts that underlie gatekeeping, so this can be done for a variety of reasons, but it's often justified using the argument that hormone therapy is dangerous and irreversible, and that it could have serious consequences for people who use it. And so we, as those prescribing it, have a responsibility to be selective around who we give it to. The concern for those who are proponents or who support the idea of gatekeeping is to say that patients might either regret the decision that they make or suffer irreversible side effects from it. And it's our responsibility as the clinicians to ensure that this is the correct course of action. Of course, this is a rather problematic idea because it supposes that we know better than a patient and that the patient doesn't have the necessary understanding of their own lived experience in order to make an adequately trustworthy decision. And it puts a lot of burden on the healthcare provider as well as unfairly prejudicing the patient in that they need to prove their identity in order to gain access to care. You have to prove to your doctor that you are in fact trans enough. Otherwise, you might not be able to get access to the kind of care that you need. And the frameworks that we have used as clinicians for determining if someone is trans enough are often very ill-informed and sort of particularly ill-suited to a group that is as diverse in their experience and their expression as trans people. So it tends to minimalize trans experience and try to fit it into a set of boxes, and that being a set of boxes that were originally defined by people who didn't have lived experience as being trans. In order to gain access to care. And this is where ideas like the concept of real life, real lived experience, or RLE, that we used to see in some very much older and now unfortunately obsolete guidelines, although some clinicians still try to enforce these, you must prove that you can live in your identified gender for a set period of time before you get access to care, or you must undergo a fixed duration of psychotherapy in order to get access to care. And obviously, as you can understand, um, when someone seeks mental health care services or counseling or therapy or psychology, their needs are vastly different. And to say how long someone needs to be in therapy because they're trans is it's a flawed question ultimately. Some trans folk won't need therapy at all. Some trans folk will need extensive therapy, but for reasons other than being trans. So it kind of plays into the idea that trans identity is in itself somehow pathologized, and there's a much broader conversation to be had around that, and certainly a much more nuanced one. But understanding this is quite important. And, of course, we speak about dangers and side effects, but we know that as clinicians, almost all of the interventions that we prescribe for patients are potentially dangerous and can have side effects, from antibiotics to paracetamol to medication for high blood pressure. And we don't apply the same rigorous lens of scrutiny when we prescribe those medications. If a patient has high cholesterol, we're often very quick to put them on a statin um, without really giving credence to the fact that the medication might cause some debilitating side effects. So, it comes down to a fundamental question often around necessity and a desire on our part to not see gender affirming care as a necessity. And of course, I would argue, as would many others, that it is. And so any risks that do come along with gender affirming care should be seen as part of a necessary process um, rather than a concept of cosmesis. So that's gatekeeping in a nutshell. And on the other hand, to gatekeeping, you have a model called informed consent. And informed consent tells us that patients have a right to choose. They get to decide what happens with their own bodies. And again, this is applicable to gender affirming care. It's also applicable to any other kind of medical treatment for the high blood pressure or the dyslipidemia, or the diabetes, as we've spoken about, or any kind of surgical intervention. And under the informed consent model, the responsibility of the clinician or the provider is to educate the patient about risks, benefits, side effects, timelines, etc. The kind of information that we understand because of our experience and our training and our knowledge and the resources we have, which patients don't necessarily have access to. So it's our job to interpret that for them and to give them as broad and as full a picture of how the medication works and what it does as possible, so that they can make their own decisions around this. And of course, it's right there in the name. It's not just consent, it's informed consent. So your responsibility is to give the information, and the responsibility of the patient is to decide whether or not they consent. And this model is of course attractive for a number of reasons, and we'll contrast the two through an ethical lens in a moment. But certainly this model absolves the provider or the clinician of the responsibility of determining who's worthy enough to get access. It makes it your responsibility as the provider to understand how the interventions work and to explain that to your patients. Of course, the prerequisite here is that in order to give consent, someone does have to be of legal age to consent to medical intervention, and also needs to have capacity. So one of the questions that we often get is, well, what about mental health and coexisting conditions? And this really tells you that as long as the patient isn't out of touch with reality, doesn't have impaired reality testing, or doesn't have impaired cognition or judgment, they are able to give consent, even if they do have coexisting mental health conditions like anxiety or depression, for example. So it's really just your job to ascertain if this patient can understand the information that you're putting before them and appreciate what it means and what the consequences of that would be, and then to make their own decision. So I would like to take you through a little exercise where we are going to compare these two models of gatekeeping and informed consent through the lens of these four pillars of medical ethics. And there are a variety of ways that you can do this. But I think that sometimes employing a case study or a vignette is a little bit helpful, and we'll do that as we progress. So if we take a look at the first pillar that we have, beneficence, are we giving a benefit to a patient if we stop them from accessing hormone therapy, gender affirming hormone therapy, or if we require them to prove themselves in order to get access to that treatment? Now, there is a substantial body and of evidence, and a growing body of evidence, to say that there is significant benefit to allowing trans patients access to a gender affirming care in terms of social outcomes like employment and homelessness and substance use, as well as some very clinical outcomes like the prevalence of attempted or completed suicide, for example. So if you were to look at these two ideas, by restricting access, are you actually giving someone a benefit by saying to them, you need to go through a fixed period of psychotherapy, or you need to live in your assigned gender, which we know it can be very difficult to do without adequate clinical support. And I would argue that it becomes very difficult to say that there's beneficence in restricting access. The whole idea behind that is that we need to protect patients from themselves, but it isn't actively helping them, because they might still be living with dysphoria if they experience it, or distress, or social difficulties. Then, of course, on the other hand, the informed consent approach, which allows access, and as we know, there are some significantly beneficial outcomes that have been strongly linked to providing access to care. The second pillar that we're going to look at is non-maleficence. And I think this is probably the one where the argument becomes the most nuanced, because of course a lot of the fundamental idea behind gatekeeping is to protect patients from themselves, to not do any harm. And it is an attractive way of thinking to say that if we take a little bit more time, we're not doing any harm. Whereas if we were to provide this medication to someone, we could potentially be harming them. So, of course, as we've discussed, a lot of the medications that we use are potentially quite dangerous to patients. It could be hepatotoxic or nephrotoxic, in the case of some of the antibiotics or the ARVs or whatever else. But ethically, we don't have a problem prescribing these, because even though it is potentially harmful in a minority of cases, we do take measures to ensure that we're doing it safely, or otherwise to ensure that the risk is outweighed by the benefit. The other thing that we know is that denying people access or restricting access or forcing them to wait isn't as passive a process as many people would want to believe. So there are certain negative and deleterious outcomes that result directly from stopping people from accessing medication and, or let me say, from accessing clinical care, clinical gender-affirming care. And as we've discussed, it can lead to things like substance abuse, but it can also lead to patients self-medicating with preparations that are not suited to hormonal replacement therapy and for trans folk at all. And it can also force them to endure and live with the stigma and the prejudice and the discrimination. So there is much more of a gray area in terms of non-maleficence when it comes to gatekeeping than the proponents of this idea would have you believe, and often causing someone to sit and wait when they are experiencing distress or dysphoria can be particularly damaging. On the other hand, if we use an informed consent process, while there might be risks or side effects attached to the medication, we do inform a patient about these, and we are able to plan together with them to monitor or to mitigate those risks. So it might have to do with lifestyle intervention. If we're worried about, for example, heart disease, then we could say, you know, if you do start using testosterone, you are going to have a higher risk for heart disease. So we need to be more vigilant about watching your cholesterol. We need to be more careful about getting you on an exercise plan or an eating plan, for example. The next concept that I'm going to look at, or the next pillar, is autonomy. And I think this one is a fairly forthright discussion to have. When we use a model of gatekeeping, the decision rests with the clinician or the provider and not with the patient. When we use a model of informed consent, it is the patient's right to choose. So it's very simple to see there that autonomy is upheld and complied with by the informed consent model, whereas gatekeeping is in direct conflict with autonomy. And then the last pillar that we look at is justice. And here I'll illustrate with a hypothetical example of two different assigned male at birth trans patients. And let's say that the one, let's call her Susan, for example. Let's say that Susan is 5'6" and she has a petite build and she's got small hands and she doesn't have a very deep voice and so on. And she lives in a nice, safe neighborhood, and she's got an education, and she comes from a wealthy family. And Susan can afford to go for speech therapy and for laser hair removal or electrolysis, and she can buy the nicest dresses and clothes and handbags and makeup and whatever else. And the other patient in question, will call it Lisa for argument's sake. Let's say that Lisa, instead of being 5'6", is 6'4", and Lisa's got a much heavier build and much thicker body hair and much bigger hands and a much deeper voice, and is unable to afford waxing or hair removal or makeup, for example. If these two patients present side by side at the clinic, if we use the model of gatekeeping, which one do you think is more likely to get access to gender affirming care? And in the majority of instances, it will be Susan, who fits or is much better aligned with the cis-sexist, heteronormative, feminine ideal. You know, the clinician will look at Susan and say, you know, I can see this person as passing in society. And there's a whole discussion around passing that unfortunately we don't have time to have today. But the system is skewed in that it'll give access preferentially to those who have an easier time with the real lived experience, for example, that we spoke about a little bit earlier. And of course, so many other factors play into this, and none of it is around identity and who you are on the inside. It's more about how well you play a role that's been defined for you by the rest of society. So you can see how the process of gatekeeping, which says you have to prove to us that you're trans, is inherently skewed towards those who have some or other exogenous or endogenous inherent advantage, and unfairly prejudices those who don't have the same advantage. So I hope that in a nutshell, we've been able to unpack these two contrasting approaches, the gatekeeping and the informed consent. And I hope that we've been able to give you a little bit of a perspective as to how you can approach your own decision making around this, and really interrogate it through an ethical lens and apply the four principles in a way that makes sense to you and in a way that is ethically sound for your patients. And I hope that you've realized some of the nuances and intricacies involved in this process, um, and really that it'll open the door to a little bit of reflection and understanding around just how dangerous and indeed unfair, and I'll go so far as to say unethical, an approach based on gatekeeping can be, and how an informed consent approach, although it might seem scary to the clinician at first, is in a lot of ways, or at least I would say almost comprehensively, is a much more ethically sound approach to treating and caring for your trans patients.